Welcome to the Speaking of Women's Health CME podcast. I'm your host, Dr. Holly Thacker, the Executive Director of our nonprofit, National Speaking of Women's Health. Today's CME podcast, which is being recorded on February 3rd, is supported by a grant by Astellas and Bayer Pharmaceuticals in conjunction with Rush University, Plexus Communications, Advancing Health After Hysterectomy, and our nonprofit Speaking of Women's Health. And you can find out more information about this free CME podcast and other CME lectures and opportunities that we have on menopausalearning.com. It's really a great pleasure of mine to invite and welcome, joining us on this CME Women's Health podcast, Dr. Camille Moreno. She has been an active clinician and a researcher, and she directs the Women's Health and Midlife program at the University of Utah, and she's an assistant professor in OBGYN. She is an avid runner and hiker. She has been a staff at Duke University before moving to the University of Utah and enjoying those beautiful mountains. And she completed a 2-year fellowship in specialized women's health at the Cleveland Clinic. And she was just really super outstanding. And it's such a delight to have her here. And I would recommend that everybody go on menopausalearning.com and you can click and get the bio of all of our faculty, including Dr. Moreno, and see their pictures and their links and information about themselves. And I really liked her introduction when she talked about midlife and menopause as just being a celebration and a transition in a woman's life. And I just think that's a fabulous way to incorporate the preventive aspects, the medical aspects, and just the holistic approach and the individualized approach to menopause. So thank you so much, Dr. Moreno, for joining us today. If you tell us a little bit about yourself and where people can contact you, or if there's any social media or anything about your program in Utah that our listeners should know about.
Thank you, Dr. Thacker, for that generous introduction. I am very honored to be a part of this wonderful podcast, and also for CME credit, which is just as outstanding. Like what Dr. Thacker was saying, I am with the University of Utah OBGYN, medical director of the Midlife Women's Health and Menopausal program. And we do have a website that you can access to find more about healthcare, specifically in midlife women here out in Utah. And it's healthcare.utah.edu/womenshealth/midlife-care. And that is the best way to get a hold of us and to reach us and to find out more about the program and the community that we're serving here in Salt Lake City and beyond.
And tell us a little bit about your practice and just your approach to midlife women's health.
Yeah, so I actually have dedicated clinics specifically for menopause and perimenopause. So really that's addressing the bothersome, quality of life symptoms that affect about 70 up to 85% of midlife women. And those are your classic, what we call vasomotor symptoms, which comprises hot flashes, night sweats, even sleep disturbance, but also the non-classic symptoms that women also are concerned about, including worsening anxiety, depression, even joint pain, polyarthralgias, brain fog, lack of focus, fatigue. So those are my day-to-day stories that I hear from my patients. I also run a dedicated vulvar disorder clinic here. So as you know, vulvar disorders that include lichenoid diseases such as lichen planus, lichen sclerosus are also prevalent in midlife women. So I also dedicate my practice to the care, evaluation, and non-surgical management of a spectrum of vulvovaginal disorders.
And tell us a little bit about some of the alternative and holistic options that you incorporate into your practice.
Yeah, so just recently, actually, we have offered non-hormonal as well as non-prescription therapies for management of vasomotor symptoms, and that also includes referring to acupuncture therapy or doing self-acupuncture, self-care, and really providing our patients with behavioral techniques and self-care management, such as meditation, breathing techniques to, for example, help with insomnia and sleep disturbance.
And could you talk a little bit about the vilification of menopausal hormone therapy and why many women are fearful of hormone therapy or maybe have actually legitimate reasons to avoid hormone therapy for their vasomotor symptoms?
Yeah, so I think this history really dates back to the publication of the Women's Health Initiative, also known as the WHI, which was published in 2002. And really that scared a lot of women and even, physicians and medical health providers away from really prescribing menopausal hormone therapy for the right individual. But now we have a better understanding and new evidence and long-term data that support that for the right woman within the right time, and also for a healthy woman within 10 years of menopausal onset, menopausal hormone therapy is safe and effective, and it's still the number one most effective treatment for vasomotor symptoms. And so for women who are at risk for menopausal hormone therapy, since not everyone is a good candidate for hormone therapy, then we can offer those complementary or alternative therapies to help with those bothersome flashes, sweats, and sleep disturbance like acupuncture.
And what efficacy do you tell patients in terms of acupuncture having on vasomotor symptoms or musculoskeletal symptoms? And does insurance typically cover it? How receptive are patients to acupuncture?
Yeah, that's a great question. So typically in our area here in Salt Lake City and the surrounding communities, acupuncture is not well covered by most insurance plans. And so it is an out-of-pocket cost, although for certain individuals with certain plans, they can be on a payment plan, just so that they don't have to pay the big out-of-pocket cost amount at once. And so that they are set up with a financial counselor, a financial manager in the clinic to come up with a payment plan. And as far as efficacy, we need more sham-controlled studies to prove efficacy of acupuncture. But again, for those women who are not good candidates for menopausal hormone therapy, this is one approach that is a good, safe, and also proven to help with not just the joint pain but also sleep, and as well as hot flashes and night sweats.
Can you talk about the recent North American Menopause guidelines on the treatment of vasomotor symptoms and how they've changed, and what your assessment of that is and how helpful that is for practicing clinicians, physicians, APPs, everyone in the healthcare field?
Mm-hmm. Yeah, the North American Menopause Society, also known as NAMS, really focused on, the window of opportunity, or that timing hypothesis. So again, like what I mentioned earlier, for women who are really bothered by their vasomotor symptoms and really have tried even over-the-counter supplements such as, black cohosh, soy, and other phytoestrogen supplements, and really have noticed no difference or no effect, hormone therapy is effective if started or initiated less than 60 years of age or within 10 years of a woman's final menstrual period. And for those women who are overall at low risk, including those who don't have a history of stroke, heart attack, estrogen-sensitive cancer such as breast cancer, and also history of a venous thromboembolic event such as pulmonary embolus, and a deep venous thrombosis, these women are overall at low risk for menopausal hormone therapy. And so, again, it is not for all women, but for most women who are bothered by their symptoms, it is a good way to ask your physician and healthcare provider about your candidacy for hormone therapy.
Now, when you talked about women under 60 and within 10 years of menopause, isn't it and or? Like, because what if you're in menopause at 57 and you're starting to have bad hot flashes at 66? Mm-hmm. Like, how do you handle those women?
Yeah, so we really time it based on a woman's final menstrual period and when those symptoms started. So, the average age of menopause is between 51 to 52, but in, less than 5 to 10% of women, it can be later. And I've seen as old as 59 to 60. So their chronological age is different, and their initiation of hormone therapy will be different than the average menopausal woman who goes into natural menopause in her early 50s.
Mm-hmm. So what are the barriers and the problems or the issues that you would prefer to avoid hormone therapy, or your patients also would as well?
Yeah, I think, again, history of an estrogen-sensitive cancer, and they're really not truly in remission, and some of them are even on anti-estrogen treatments for, chemoprophylaxis, such as an estrogen-sensitive breast cancer, for example. But those women who've also have known cardiovascular disease with recent, myocardial infarction or a heart attack, which is the number one killer in women, and this month is a heart health month, and it's important to know that and be aware that that is the number one killer in women. And so that would be a contraindication to menopausal hormone therapy. But this really truly provides us with a new perspective that we can even intervene before their menopausal and postmenopausal years when it comes to addressing cardiovascular health risks. And we do a poor job as a medical community communicating with our patients and really lay women that, estrogen has cardioprotective effects. And once we lose that, that increases our risk of what we call cardiometabolic health changes, including our risk for high blood pressure, high cholesterol, insulin resistance, and metabolic syndrome as a whole.
I just saw a patient today, and she was very, very concerned about stroke risk. And her blood pressure was very high. She had white matter changes in the brain, but she wasn't really concerned about the blood pressure as much as the hormone therapy. And she's under 65, which the WHI did not show, even with oral hormone therapy, any increase in stroke risk in those under 65, but certainly one extra case per 1,000 women over age 65. So I just think, the cardiac risk factors, if you want to go over the major ones or the ones that are specifically related to being female.
Mm-hmm. Yeah, and those are the women-enhancing risk factors, which are now emerging research topics, actually, that, the heart health community and researchers are currently studying. And that includes a woman's history of gestational diabetes and hypertensive disorders of pregnancy, including preeclampsia, eclampsia, and chronic hypertension that it presents with that after delivery or postpartum. And so that is one aspect of where we can intervene, again, earlier on in a stage of a woman's life, not necessarily when they enter perimenopause and menopause, but even during their reproductive years.
I think that's such a good educational point. And a lot of times, if we're not doing obstetrics, which in general, if you're in the post-reproductive phase, you're not, a lot of times there's not attention to that obstetrical history. And that is really critical in terms of it translating into later cardiovascular risk and other risk. Like when I was presenting at a conference on sleep, since menopausal hormone therapy can certainly affect the quality of sleep, and a lot of vasomotor symptoms happen at night and therefore disrupt sleep, depending on the sleep cycle, that they noted that there was a 90% increased risk of obstructive sleep apnea if you've had gestational diabetes. So I pretty much almost screen for sleep apnea in pretty much all my midlife women, particularly if they complain of fatigue or weight gain or brain fog.
Yeah, because half of women who have an underlying sleep disorders are not necessarily just due to night sweats or hot flashes at night, but also because of undiagnosed and untreated sleep apnea or even restless leg syndrome, which needs to be evaluated as well. And I also want to mention that premature menopause, which is menopause before the age of 40, also presents as a cardiovascular risk. And these women are 3 times as highly likely to develop these cardiometabolic comorbidities well into their 60s. So that is an intervention, specifically estrogen replacement intervention, that needs to happen as soon as their ovaries lose function a decade before the natural age of menopause.
Now, there is a relatively high burden of cardiovascular disease, particularly with increasing age. So in those women over 60 who have known heart disease, do you preclude or take them off of hormones? Do you continue hormones with other agents like statins or other interventions? How do you deal with women who've got known cardiac disease, who also have vasomotor symptoms and have maybe other indications or want hormones?
Yeah, and that really takes an individualized approach, right? So it depends on the woman's, again, health history, how stable those chronic conditions are, how well maintained and her medications are, and if she has really any new diagnosis that could affect her cardiovascular disease risk in her postmenopausal years. But in women who are on hormone therapy and overall still needing it because they've tried weaning off or stopping their hormone therapy and they just noted, return of bothersome night sweats that really have caused poor sleep. In those women, they've done a trial, they've proven to you that they still need it, but age is the biggest risk factor for them. And age is a risk factor for a lot of things, not just heart disease, but also cancers and stroke and heart attacks. So with that counseling, I typically recommend perhaps lowering the dosage, because our understanding in theory as we get older, the risk is there, and so lowering the dosage of estrogen can also lower the adverse risk or the adverse events that come with age, especially if they're still needing it. I don't typically stop or discontinue, but counsel on lowering the estrogen dose.
Do you switch to transdermal if you think there's cardiovascular risk, or do you not if they don't have DVT risk?
Yeah, so I typically also include that in my discussions, switching if they are on oral estrogen therapy, switching to transdermal, which is overall a safer formulation because of that first pass hepatic metabolism effect. So based on observational data, we do know that the type or the formulation of estrogen does matter, and transdermal estrogen has shown to overall decrease VTE, or a venous thromboembolic event, compared to oral estrogen. And when they study this, it was either estradiol, which is considered bioidentical estrogen, versus conjugated equine estrogen, which is a mixture of estrogen and not bioidentical.
Yes. It's interesting, though, in I think younger, healthier women without cardiovascular thrombotic risk, the DOPS study, which was a 10-year study, Danish osteoporosis study in women using oral estradiol with progestin, actually they showed less heart disease, less DVT, less osteoporosis. So sometimes I think we're too quick to go to transdermal. And then if you separate the estrogen and the progesterone and they have a uterus, technically that's not FDA approved unless you're cycling the progesterone. And certainly in women over 60 or 65, they don't really tolerate any kind of bleeding, and so that's always a bugaboo. So I kind of like the combination, and there's only 2 combination patches with estrogen progesterone, either the weekly Climera Pro, which is estradiol and levonorgestrel, or the twice a week, which is actually every 3.5 day combi patch, estradiol. And a lot of times we'll cut these patches in half in older women, and that makes it a lower dose for those older women and more cost effective. So talk about the changes in the North American Menopause Society's recent update guidelines, and do you think that's helpful? Does it really influence your practice at all? You probably were already ahead of the curve anyway.
Yeah, so I do think that it is reassuring to know that the main principles of my practice follow the North American Menopause Society. Again, that timing hypothesis and window of opportunity in really individualizing a woman's personal health risk factors is important. They also have removed certain contraindications to menopausal hormone therapy, including growth of uterine fibroids, or what we call leiomyomas, as well as porphyria cutanea tarda, which is a liver disease or presents with liver manifestation in very rare cases. So they have updated those as well. But again, for the majority of healthy women who are symptomatic and bothered by their symptoms, it is worthwhile to have that conversation with a woman in front of you and not just dismiss the symptoms that she's been experiencing and been bothered by, especially if she's a good candidate for hormone therapy. That is an effective option to counsel her on.
Yes. Do you find many women in your practice on adequate doses of hormone therapy who still have vasomotor symptoms, and what do you do in those women?
Yeah, so that's a great question. And are you asking specifically women who are well into their 60s who all of a sudden have return of bothersome hot flashes?
Yes, that, or just even younger women, hysterectomized women, or naturally menopausal women, any of those profiles.
Yeah, so there are certain factors, and it doesn't have to be just biological, but also mixed with psychosocial cultural factors. But in women, we have a better understanding that women who have been hysterectomized before the age of 45 actually enter menopause and experience those bothersome symptoms a lot earlier on than the average age. And that is even in women who have their ovaries in place and have not been removed. So there is an understanding that overall with the surgery or the procedure itself, the decrease in blood flow to the ovaries happened, and that may have led to decreasing ovarian function even well into their 50s, especially if they're hysterectomized before 45. And for women who reach menopause prematurely, and when I mentioned before the age of 40, really they do suffer the most. And it's not just your classic symptoms, but it also affects their libido or sexual function, because half of our testosterone in the bloodstream, and yes, women also produce testosterone, not just males, is produced by your ovaries. And that is also an important factor to note, that depression and low libido are more prevalent in prematurely menopausal women. And for those women, for example, who went through menopause, breezed through it, really didn't have any symptoms, it could be partly genetics, right? So a woman may tend to follow their older sisters or mom's journey into menopause. Genetics does play a role, and it's not just the environment or the situation that you're in or medications that you're on that are affecting it, and even your health history. But that truly needs an evaluation, especially if a woman comes to you in her 60s and maybe even 70s, and they tell you, "Doc, I'm having really bad hot flashes. I don't know why. I went through menopause just fine, and then all of a sudden experiencing this." And that takes an evaluation, because it doesn't necessarily mean that is related to loss of estrogen, but it could be related to other conditions, including malignancy or cancer, and that needs to be further evaluated. And even medications, typical SSRIs, SNRIs, which are used as off-label prescription therapies for hot flash management, may actually worsen hot flashes in some women. So that is something to note, is looking at the medication list and seeing if there are any side effects of these medications that cause hot flashes.
I've seen some older women with no hot flashes who then later in life undergo oophorectomy and have symptoms, particularly if they've had to have an oophorectomy for a fecal cell tumor that produces hormones. And I think that anything that reduces adrenal reserve, which age does, certainly some medications, that could be a trigger for flashes, as well as weight gain. Sometimes people just complain of being hot overall. So you do see a role for giving off-label testosterone, especially in the younger women or the oophorectomized women?
Yes, that is one that I truly highlight in my counseling with my patients. There is a role of off-label therapy with topical testosterone that is used about a tenth of a dose of what we would prescribe males, and that is overall safer. And with your, trusted compounding pharmacies in the area, you can send this prescription and they can custom compound it based on, your needs and based on the woman's, list of irritants that of the bases that this testosterone gets compounded. So again, there is a role, especially if they're bothered by low libido, overall decreased sexual function, fatigue. Those are the common symptoms that I would address.
And do you have any tips for practicing physicians and APPs and physician assistants who prescribe testosterone? Like, do you just recommend only finding a local compounding pharmacist that you trust, or do you use any national compounding pharmacies, or any tips or recommendations? Since, of course, most of the major medical organizations do not recommend compounding unless that's your only option or someone's allergic to a formulation.
Right. So that's a good point. In my world, I do use compounding pharmacy, especially with a trusted pharmacist that I know will do a good job. But in other people's worlds, that might not be the case, and they may not even have a lot of compounding pharmacies to choose from. So you could use Testim or Androgel, similar to the ones we would give males. But again, instead of the 100 milligram dosing that you would offer a male patient, you would prescribe 10 milligrams of that for a female patient. With that being said, I have tried that maybe in the first year of my practice, but just from my anecdotal experience, it was a lot harder for me to explain to the patient how to measure 10 milligrams and, asking them to buy a syringe off of Amazon and then measuring 1 cc of this syringe was really complicated. And so that's why I turned to a trusted custom compounding pharmacist.
Mm-hmm. Yes. And we may have some pharmacists tuning in.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
To this, and do you know of any national resources? I know, like years ago, before we had Prometrium, which is natural progesterone in peanut oil, I always used the Women's International Compounding Pharmacy in Wisconsin, and I know there's a big compounding pharmacy in Texas, Empower, that has licenses in other states. I primarily use a PharmD locally at the Cleveland Clinic that we've worked very closely with. In terms of getting the pH and all the vehicles, as well as the percent of testosterone or vaginal DHEA just right. But it does take a lot of work, and it's harder, and a lot of times insurance doesn't cover it. Do you use the one formulation of oral esterified estrogen with methyl testosterone?
Yeah, I do that for patients who have been hysterectomized and earlier on. So whether they had the hysterectomy before the age of 45 or even a hysterectomy with a BSO, so a bilateral salpingo-oophorectomy because of, a risk-reducing surgery, for example, for cancer, predisposition to cancer, then I do use that, especially if they take the ovaries out, I have to replace the testosterone. So there is a role in estratest or conjugated estrogen with methyl testosterone. I do surveillance labs, I do baseline labs, and then also a few months after, so between 3 to 6 months after oral ester test. And if really it's the dose that we have found for the patient to be a good fit, it's helping her symptoms, it's replacing her estrogen to overall decrease her risk of cardiovascular disease, bone health risks, and tolerating it well, then I do every 6 months to 1 year testosterone levels.
Yes, I used to do that early in my practice, and then I just really haven't seen any hepatic effects, so I don't. But with increasing obesity and fatty liver, obviously, I think screening at least some of the time for liver functions is a good idea.
Mm-hmm.
So ester test, I think, was made by Solvay, but it's not made anymore, so they're only generic equivalents. And I find a lot of insurances won't cover it because they say it's not FDA approved because the drug was on the market before the FDA was even around. Do you have any tips for patients if they have trouble getting their prescription hormone therapy?
Yeah, that is unfortunately the bane of my existence most days
Yeah,
of the
mine
week
too.
when I'm seeing patients. So, GoodRx is one way where I refer to patients as a website where you can get a coupon that you can email to yourself, text to yourself, print, and you don't run your insurance with that prescription. And for your typical average estradiol and micronized progesterone, you can get the combination for less than $20 if, again, you're doing it orally. For the transdermal estradiol, so the patch form of estrogen, I do find that those are really get to be really expensive, and there are GoodRx coupons, but still not as affordable as the oral estradiol. But that is one way I do use it. Some of the pharmaceutical companies, especially if they don't have Medicare insurance for some, they can use the pharmaceutical coupon card or pay card where they get a certain supply of, for example, their vaginal estrogen cream for a certain amount.
My nurses wrote an excellent column on our nonprofit Speaking of Women's Health. I'd encourage listeners to go to speakingofwomenshealth.com and then in the search area on the little magnifying glass in the upper right hand corner, put in the word money, and it brings up an article on how to save money on medicines, and it links to different Canadian drug sites. And so I do give written hard copy prescriptions to my patients who take pictures and upload them and check different Canadian pharmacies. And it takes a while to get. They have to pay cash. But a lot of times they get the brand name. And I found out about this from my Medicare patients back when the DOJ had shut it down and said it was illegal. But now currently, as of today, it's not illegal to my knowledge. And so I think that's one option. I just think getting patients to be more cost conscious. I mean, I'll have people cut pills in half or cut patches in half. And I usually don't write the prescription that way. I put it in the note and I write it in their patient instructions because I find that the pharmacist will call my office, no, you can't cut the patch in half. Or, even if you have a scored pill that you cut in half, then they only dispense 45 pills instead of 90 for the whole 3 months. So that's a little trick. But I do think cost is a barrier, which is a shame because these drugs have been around for decades, most of them. Just like insulin costs pennies to make. And I certainly on my own time and dime have done lobbying at the state and federal level on the pharmacy benefit managers because they're the middlemen that set the formularies and really, unfortunately, affect the market and drive up costs ridiculously. And it's a shame because a lot of our patients won't take medications or reduce the dose or, make the patch last longer than it's supposed to, which then causes bleeding, or it just can lead to a myriad of problems. And any other final tips or clinical caveats that you want to give to our audience on menopause and treating women, and any other resources or updates or other guidelines besides NAMS? Any other thoughts?
Yeah, so I think that it's important to remind ourselves that this is an important topic or questions to address, especially for midlife women within the 10 years of menopausal onset, if there is benefit to counseling them on menopausal hormone therapy or even other non-prescription, non-hormonal, and complementary therapies. So women should not be suffering alone. We have numerous treatment options, again, depending on their health risk factors that are available, and with certain, again, either coupon cards or insurance coverage, we can help provide the hormone therapy at a more costly and more affordable manner. So, and it's also important to note that it is more than just that quality of life symptoms that we should be addressing. It's also important to address a woman's bone health risk, again, cardiovascular risk, and their risk for dementia, because all of those are health domains that are important when it comes to providing midlife women's health care and providing it in a comprehensive manner.
Well, thank you so much. You've all been listening to Dr. Camille Moreno, a board-certified family medicine physician who's credentialed in menopause, assistant professor at OBGYN, and she directs the Midlife Women's Health Program at the University of Utah. I'm your host, Dr. Holly Thacker. Thanks for joining us in the Sunflower House for this CME podcast. And I just remind you to go on menopauselearning.com to claim your CME credit. And we have many lectures on many different topics: heart disease, breast cancer, our town hall series. We have some upcoming events for your patients, for laywomen. So please check menopauselearning.com, as well as speakingofwomenshealth.com. And we hope that you will join us for future CME podcast, and you can subscribe to any place that you get your podcast: Apple, iTunes, Google, Stitcher, radioinfluence.com. Thank you so much.